Next. Slide changes. That's a point.
Thank you very much, Dr. Irfan for such an elaborate introduction. I would like to thank Shalom Hospital for this invitation to share my experience of robotic surgery at PKLI. And thank you to the audience and thank you to all the professors being present, for attention to this presentation and this talk. Dr. Irfan has already introduced me, so thank you very much for that. I have no conflict of interest to disclose while making this presentation. And, coming down to the topic for today is that I'm going to share my initial experience of robotics. The first 100 cases, though we have performed almost 140 cases so far, but this is about the first 100 cases, how we've taken on. Pakistan Kidney University and the Research Center. So, I mean, it is a simple question. If I ask myself how I would feel if I've been asked to come down from my bicycle to be on feet. So in my personal experience, because fortunately, I've had the fellowship in the robotics in the US, and I have 14 years experience of robotic surgery in the Europe. My initial experience was with the superior type of the machine, which is the Da Vinci robotics. So for me personally, it was not an upgrade, it's a downgrade. So if you ask my personal experience, I'm going to rate that in that way, that for me personally, it was a downgrade of experience. However, when I see it from a different perspective, that I've been part of introducing the robotic surgery, and I've been part of establishing the robotic services, not only in PKLI, but in Pakistan, I take that as a privilege. So from that point of view, I would say that experience has been wonderful so far. Now, my experience is not only with the robotics. So I'm going to share my experience at PKLI in Pakistan and with the CMR system of robotics, which is not slightly different, but very different from the system on which I've been trained. At PKLI, fortunately, I won't brag about it, PKLI is the only institution where we have two, the fully trained robotic surgeons. We both have the fellowship. My colleague, Dr. Nauman, has been trained for a year in Paris for the robotic surgery on the Da Vinci SI and XI, both the machines. I had my training in Ireland for 2 years on the robotics. Now in Pakistan, I have to give the credit to the Punjab government and whoever took the initiative for bringing up all this, I would say the cutting edge technology to Pakistan. So the idea was already there, but we had to just force it to realize, to purchase the robots and to get going with the surgical procedures. Now, robot is not the machine. Whenever we talk about the robot, it's a program. It's about the machine. It's about its directives. It is the steering body, and it also includes the case selection, the multidisciplinarity meeting, and finally, to have the outcomes and share those outcomes to have the feedback. Thankfully, we have, as it is always there in all the cases of the robotics, we have the online technical, the support from the company, and we have the online the support. Now, increasing the robotics is nothing new. It has always been there. It is a type of minimal invasive surgery. We all know. We all know it is not a rocket science. There is nothing new in it. The laparoscopy, the keyhole surgery concept was already there. It is just an upgrade of the minimal invasive surgery. However, from few aspects, it has made a significant change to the patient and to the surgeon both, and to the system as well. It combines advanced technology with the surgical expertise to enhance the precision. Now, when we talk about the precision, it's a buzzword. Now, precision means high resolution, high definition, 10 times magnified image, a 3D image, and indocyanine green, which is ICG, near infrared fluorescence technique, ICG technique when you combine it, and then the superimposition or the fusion of the images, and on top of everything, since the incorporation of artificial intelligence into the robotic system, only sky is the limit. The other advantage I'm going to talk about on the robotics is the dexterity. We can reach the body cavities where our hand cannot reach. We can see those parts where the human eye cannot see. For example, yes. So as I've already mentioned, ICGNIRF, which is indocyanine green, and you can see this green shade. Now, while you are doing the abdominal surgical procedures and you need to identify the ureter, you can inject this agent, the fluorescent agent, into the ureter to give you a better identification of the ureter. You all have heard about putting a double J stent or a ureter or a urinary catheter. Either you do it yourself or you've been requested by the general surgeons to do it for yourself to identify the ureter operatively. However, from being an instrumentation, if you just inject this dye, you can have a better view robotically. Now, as I've already mentioned about the superimposition of images and the fusion of images, if you have done an MRI, you can have a three-dimensional color-coded image. And now with the artificial intelligence incorporation into the robotics, what they're trying is to incorporate that in the real-time camera. So basically, when you're doing the robotic surgery, they incorporate that image into your camera and you can see the three-dimensional color-coded image that actually helps you in identifying the tumors, especially when they're endopedic. And then you've already heard about this thing. It is also nothing new. You know the single port. Now, the single port in the robotic has 3mm arms. So with those 3mm arms, you can reach anywhere you like. 3mm is smaller than not only the human hand, but the finger. And you can reach anywhere, you can do any angle. And you can also move the robotic arms at 360 degrees. Now, briefly, talking about the history of the robotics, it looks that it's a very new technology. It is not a new technology. It is there since 1995. Then 1991 and in 2000, the Da Vinci brought in the robotic system and they started to do the human surgeries, and they had the patent that was until the year 2013. But into the legality, they have extended it up to the 2023. And in 2023, the patent is off, and any company can develop or make the machine called a robot. So therefore, at the moment, we have 3 robotic systems operating, including what we have, the CMR robotic system, other than the Da Vinci. And recently, we've also the Medtronic robotic system called Google. So there is three robotic systems already in the market, operating in on the human bodies, approved by the FDA, and there's two more to come, and an Indian and Iranian model. So it is not a new technology, it is not an old technology, but I was surprised when I came to know about this, that it goes back to 20th century, and we are the pioneers into the robotic surgery. So the concept was already there, always there. It is not a new thing to think about, that it is, the reason, yes, artificial intelligence could be a newer concept into the medical science, but the robotic system was always there, and we inherit that, the technology. Now, from that history, the most important thing to realize that the robotic system has not only changed the surgical approach, it has completely changed the paradigm from the theater to your office. Having the mask, the cap, the scrub, the gloves, to wash your hands, and being theater, in the green gown, that picture has completely changed by the robotics. You can operate while you're in your office. You can operate while you're at home. You can operate while you're not even on that continent. So with the 5G technology, the people can operate from anywhere in the world. And that has changed the surgical, basically the scale. So if you need a mentor, if you need basically the supervisor, it doesn't need to be in theater. It doesn't need to be with you. He can help you from anywhere. Introduction of the robotic surgery in Pakistan. I'm talking about the history, I'm talking about in the world. Now, when we talk about the robotic surgery in the world, I have purposely omitted the slide that how many robots India has, how many robots America has, because unfortunately, we've been obsessed by the West, that everything is in the West, and we continue to compare ourselves, by the West or with the West. We quote the European guidelines, which have nothing to do with us. The Pakistani cancer, I would say Pakistani cancer, the Asian cancer behaves in a very different way. The squamous cell incidence and the prevalence is very different in Pakistan. So we cannot apply each and everything from the West into the Pakistan. We have to have our own experience, our own original experience, and our original data, which we can incorporate into our society, our culture, our practice. So in Pakistan, the history dates back to 2011. The first robotic system in 2011 was purchased by a private company in Karachi. That was taken over by the civil hospital, but unfortunately they were unable to do the required number of cases. As I already mentioned, the robot is not a machine, it's a program. So if you buy a machine, you have to have certain number of cases, and before that, you have to decide how many cases you can operate on the robot. You have a year. So if you're unable to perform at least 30 cases a year, then basically the company has the right not to give you the technical, the support, be it online or on-site. So now, the first was in 2011 privately, then the civil hospital, but unfortunately they didn't have enough number of cases. And I would say the main reason was that they did not have the trained surgeon and were dependent on the colleagues, the Pakistani colleagues from the UK, to invite them and operate. So for that reason, that was not a success. Then the first successful robotic thing was introduced and established by SIUT Karachi. So they were the first actually people who inherited that robot, and then they bought their own robotic program, and they're doing it successfully. So, and after that, a private hospital in Punjab was the one to buy the robot, and PKLI is the third one. However, PKLI is the first in the government, basically the sector. When I say government sector, that means that if a patient wants to have robotic surgery, he can have it free of cost from the taxpayer money. I've already mentioned about this. SIUT and the CMR thing. Now, I'll come down to PKLI experience. In PKLI, as you all know, because PKLI is not like private hospital, it is it is an autonomous body. However, it is still under the Punjab government. Audit is performed by the Punjab government. So our procurements of equipment is through the Punjab government. So initially we thought that it is going to be a straightforward procedure because we have the money, we have our PKLI's own amount. Then we realized for two reasons. First of all, we have to go through PAPRA rules and the regulation, which also made it difficult for us. And the other reason was that there was only one company. There was no two vendors. So PAPRA said there has to be two vendors at least to compete and to have a fair competition. But unfortunately, there was only one. So that has delayed. So there is many years of delay just because of the policies and the procedures of the government. However, finally, we got the robot in April 2023, which is almost a year ago. And we had our case on the 12th of April. We had to have our doctors trained, though we were already trained, but we had to, we had to go to Sharjah to have the certification. We had to send our staff nurses, our technician, our CSSD staff had to be trained, and then to have the dry runs. And then after all of that, we did our first robotic case on the 12th of April, almost a year ago. And so to mention the significance, as I've already mentioned, first public robot in Pakistan. It is the second in Punjab and it is the third in Pakistan. And now there's more and more on the way. And I personally believe that we need to have this machine, this program in the government hospital. Because government hospital means that patient has the right to be treated from their own tax. So if you buy a machine in the government sector, it is a taxpayer money, and that taxpayer money has to be spent on the public. As I've already mentioned, we have two robotic surgeons, so we are fortunate. We are fortunate. We have discussions with the SIUT. We were fortunate that two of us were already robotically trained. We had the fellowship, so we didn't have any problem. So my experience is slightly biased on the robotics as compared to a person who has not done the robotics before. However, I had 14 years of experience of robotics. My colleague had 13 years of experience in Derby. So we were trained actually on the robotics and we were doing robotic program at now. Talking about the learning curve, as we all know, any surgical learning curve actually starts from the knowledge of anatomy, the aptitude for the surgery, a good experience in open surgery so that you know the anatomy, then it is better. I would not say that it is mandatory. However, it is better if you have the laparoscopic skills because I've already said that, as a principle, the robotic surgery is a type of minimal invasive surgery. The principles during the procedure is almost the laparoscopy, except that there is a robot in between the humans and the patient assisting you. Now, for any robotic program, they have an online module which you need to complete to know about the machine. Then you go onto the port training. That means that they give you 11 tasks to complete. And then they take you on the virtual trainer where you have the robotic arms doing the job. And after that, they take you to the simulation. And after the simulation, they have a human cadaveric, basically the lab in the Sharjah in the Middle East, where they take you and you operate on the cadavers. And after that, you observe, you do the bedside assistance. And after the bedside assistant, you get your hands onto the console and you become a console surgeon. So you can see in the picture that there is a surgeon who is doing the bedside assistance. So that is the first, basically the step, the bedside assistance. And from there, once you get your certificate, you get onto the console. You do your initial cases under supervision, and then you become an independent surgeon. So initially we had the criticism It's a very common criticism that we are doing the cheap cases for expensive. That means that if we were doing, a pyeloplasty, which can easily be done, cost-effective pyeloplasty by a very good laparoscopic surgeon, and in the periphery, people are doing an open pyeloplasty with a very small incision, while we are doing the cheap procedures for a very expensive. So in terms of cost effectiveness, I've already mentioned that because it is a government basically a funded institution, so we were doing it for free of cost. And now, from the medical science, science point of view, it is very, very important to have the learning curve. So you always start with the simple cases, and then you go towards the complex surgeries. Now, incorporation of artificial intelligence has again changed the paradigm even into the robotics. So, in terms of procedures, we have a robotic MDE. So each and every case is discussed into that meeting, and we select, which case is suitable or unsuitable for the robotic surgery. We are trying to do as many cases as we can, and you can see the list of the procedures. We have no case selection criteria. We have an MDT and we discuss 3 or 5 people together along with the radiologist, and we decide that this case is suitable for robotic surgery. Coming down to the machine, the beauty of these equipments is that everything is basically recorded. So if it comes to clinical governance and audit of your performance, you cannot hide because the machine has basically recorded the 4 sites, the video, and also the date and time of the procedure. So everything is recorded. Now, this is the data. I'm not going into the details of this. We have done bilateral adenolectomies, nephrectomy, pyelolithotomies, pyeloplasties, 12 pyeloplasties, pyeloplasty with the pyelolithotomy. We have done the radical adenolectomy. We have done the radical cystectomy. When I say radical cystectomy, that means the oncological part, the reconstruction we have. We have not done so far. We do extracorporeal island conduit or any type of reconstruction. We've done the prostatectomies. So almost all range. So initially we were doing only the upper tracts, and then we moved towards the lower tract, towards more complex pelvic surgeries. These are the outcomes in terms of the time we have taken to perform a procedure, the blood loss, the admission, and the stay of the patient. Because in the robotic, what we claim that we have the minimal blood loss, we have the shortest duration of the stay of the patient. In terms of pyeloplasties, maximum we had 24 to 48 hours stay of the patient in the hospital, because that way we claim that it is cost effective, that the patient goes home early. As I've already mentioned, that even the time of the surgery is basically recorded. You can see that the surgery time was 51 minutes, the console time was 42 minutes, and the active console time was 39 minutes. So a procedure of the radical nephrectomy was completed actually in 39 minutes. And that is by the system. It is not that I'm claiming to do it in 39 minutes. Outcomes, yes. As we always know that in the minimal invasive surgery, there's a term called conversion. Now, in the robotic procedures, the conversion is of 2 types. First of all, you convert to laparoscopy. You use the ligature. You use the different instruments and the different energy source. So, in the robotics, when we say we are converting, change instruments, the width of the arms, that means that we are moving from the robotic to laparoscopy, not opening the case. The other conversion is that we convert the case from the minimal invasive surgery to open surgery. Now, the conversion in opening is also of 2 types. The first cause or the reason is inability to progress. You're doing the surgery and you're not making progress. It is a complex case. There's too many adhesions. There's a lot of fibrosis and you're unable to dissect. So you say that we have spent 2 hours dissecting the kidney. We are not progressing. We are not going anywhere. We have to convert. The other conversion is when you lose control. by mistake, you end up in opening the gonadal blood vessels or the renal artery or the renal vein. That is another sort of emergency. For that type of emergency, you have to be prepared, and you also have to keep in mind. We have converted so far, the one case of the endolectomy, two cases of radical nephrectomy. One was the simple and one was the implant. And as I already mentioned, all these conversions were not to open, they were from the robotic to laparoscopy because we were unable to progress robotically. As I already mentioned, that it also basically records how many of the procedures you have performed, how many of the console procedures you have performed, and it also gives you the arm clashing. That also tells you that how skilled you are, and you can see the, basically the bar chart that is, over there. It is showing that, that arm clashing was too much, and that's, because that we have a new consultant who was having his training. So, the green line over there, that is acceptable. That line is acceptable, and you can see there's a lot of arm clashing. So by showing this slide means that the robot machine records everything. The whole of your performance is, recorded. Now, apart from the clinical side of the robotic procedure, we get the technical details. In the technical details, we get how many instruments we have used, how much diathermy we have used, how much monopolar diathermy we have used, the bipolar we have used. Do we need to change the instruments? All of that is also recorded and is part of the audit. Now, that side is also showing that, there is a bipolar and there is a monopolar and a Grasper. 10 minutes, 20 minutes, 30 minutes, 40 minutes, and you can see the bar chart showing the details. Now, coming to the conclusion, I would say in terms of robotic experience abroad or in Pakistan, we are in the transition. And in the transition, I would conclude by saying, I was in the Royal College of Ireland, and there was a professor from Paris, visited France, and he proposed this to the Royal College, because now we are intercollegiate, all the four colleges as a board. And he said the word surgery was coined by the Hippocrates. And the meaning at that time in the Greek of the term surgery was to get into the body, to get inside the body to treat the disease. And he said, instead of trying to get into the body, we are trying to get outside the body. And we are trying to get away from the body. So that is, we are moving totally in opposite direction. He said that after the minimal invasive surgery or the minimal access, basically the surgery, do we need to redefine the definitions? And that was a proposal. It was very well taken at RCSI. So I conclude my presentation at this. So are we moving to, in that direction, that do we need to change the definitions of the surgery or anything else? I leave it to yourself. It is the territory of basically it's an open field. It is a territory of unknown, and we don't know that after the introduction of artificial intelligence, how far will we go? As we always say in English, that the sky is the limit. And thank you very much for being patient.